going through medical school, I thought I knew what hospice was. We didn't spend a lot of time on it, but as I went through my clinicals, I felt like I had an exposure to hospice. I knew it was, to help with symptoms as people are dying. But that's really all I knew about hospice. And now, having dedicated, the last 7 years of my life to hospice and palliative care, I find that I really had no idea. If I could talk to the younger version of me, when I had a big primary care practice, I would do a lot of things differently, knowing what hospice can provide, what end of life could look like. And so I do think there's a lack of education, a lack of knowledge in the medical community, not only about what palliative care can be, but also more specifically what hospice is about. Now, I wanted to just kind of provide a little bit of information. So these are the other hospice programs in North Dakota. As you can see, there's a number of hospice programs in a state the size of North Dakota. And so you would think that North Dakota had really good access to or use of of hospice services, but that is so untrue. We're the third worst in the country at utilizing hospice services at the end of life. It's astonishing to me. There are entire segments of the state that do not have access to any hospice service. Now, Hospice of the Red River Valley, just a little toot. We are an independent nonprofit hospice. We have 6 offices, 3 in North Dakota and 3 in Minnesota. We have offices in Fargo, Grand Forks, and Bismarck. And then we have offices in Detroit Lakes, Fergus Falls, and Thief River Falls. So we do cover that upper sort of northwest corner of Minnesota, and about the entire east half of North Dakota, with the carve out of Minot. We serve well over 40 counties, over 44,000 square miles. We're the 3rd largest hospice in the country from a territory standpoint. And then, like most hospices, all hospices, it's a federal benefit. We have a multidisciplinary team, and our services are available 24/7. Now, the purpose of this lecture is to really enable folks to provide compassionate care to the population living with dementia. And I don't think that's ever really questioned as the intention, or very rarely questioned as the intention for caregivers. I think largely it's a lack of knowledge, a lack of knowing how or what kind of tools are available. I'd like to get people to a point where they can identify characteristics of advanced dementia, health concerns that happen with advanced dementia, and at least 2 benefits that we can provide. Hospice is really the only area of medicine that is solely focused on care for the dying. Almost all of medicine is focused at cure, improvement, living longer, all of those sorts of things. That's what I was taught in medical school. That's largely what I came to hospice with. But it's really focused around providing care for not only the patient who's dying, but also the people in that patient's circle, whether that's their family or their caregivers. Over the years, I can think of many, many, many times when I would visit with hospice patients, and I would spend much, much more time with the family than with the patient. And that's okay. That's what was needed in that situation. Self-determination is the key. Care that's individualized for the wishes of that patient and their family. So many times, the struggles that we see as patients approach end of life are very closely tied to their loss of control. Loss of control over everything, their body, their mind, their healthcare situation. I mean, so many things. And so the one thing that we can consistently give to them is control over the dying process, control over how they bring their life to a close. People ask all the time, what's different about hospice? And I think primarily it's the change in the focus. Instead of focusing on cure or living longer, the focus is strictly comfort, palliation, either prevention or alleviation of suffering, management of pain or symptoms, whatever those are. It's not always pain. Sometimes it's shortness of breath. Sometimes, there's all kinds of symptoms that we deal with. It's whatever that patient considers suffering. Care for the whole person and their loved ones. Many, many, many spouses confide that their greatest concern as they approach end of life is how their spouse is going to deal when they pass. Hospice allows for a natural death. We don't speed it up. Our intention is not to hasten death, not to stop death, not to prolong death. It's to make it comfortable. We provide hospice wherever home is. If that's a farmhouse in the middle of North Dakota, great. If that's a assisted living or a skilled facility, okay. We've even provided hospice at homeless shelters. The hospice benefit also provides for grief support, and we have a very wonderful bereavement team, and we follow the families of our patients for 13 months after the passing of their loved one, because that 1-year anniversary is often very challenging. And it's very much a team approach to care. This is not a kind of care that any one provider or one person could manage. So I also think there's some questions, especially in the lay community, but also in the medical community, is what is dementia? Dementia is sort of a grab bag of chronic diseases. Now, the most common one is Alzheimer's by far and away. But the end point of all the dementias, whether it's vascular dementia, whether it's Lewy body dementia, or whatever, they all sort of come together as a state of profound physical and cognitive disability, which is just sort of the culmination of a neurodegenerative disease of some sort. Sometimes that's Parkinson's, sometimes that's Alzheimer's, sometimes, like I said, it's other medical conditions, but advanced dementia looks very, very similar no matter what the cause is. One of the key components when I was taught about Alzheimer's disease is that it's sort of a reverse order of normal human development. So, as babies, we can smile. We learn to hold our head up. We learn to, those milestones that happen in infancy. And in dementia, it's sort of, in Alzheimer's, it's sort of described as a reverse order. Now, not all dementias progress that way. That is very specific to Alzheimer's. But a lot of providers sort of think of that as the progression of dementia. When we talk to families about dementia as a terminal diagnosis, they're shocked by that. They thought dementia was much more a symptom than a terminal diagnosis. But the decline that is seen with dementia almost uniformly leads to death, usually by infection of the lungs, the urinary tract, the skin. But the decline in and of itself creates a situation where that almost universally happens. As I said earlier, Alzheimer's is the most common form of dementia. In 2017, it was the 6th leading cause of death in the United States. And it sort of fluctuated in the, in the top 7 since then. 1 in 3 people die from Alzheimer's or one of the other forms of dementia. And between 2000 and 2015, the rates of Alzheimer's disease increased phenomenally, and it's continuing to do so. By 2050, I believe the projected numbers are something like 15 billion people will have Alzheimer's disease. But it's a challenging diagnosis, not only because it's hard to manage, but also because it's hard to sort of navigate when people progress differently. So what does advanced dementia look like? So we've been talking all day about advanced dementia, terminal dementia. And these people often have severely impaired memory, which starts long before. They get to a point where they are very difficult to engage. I really love the first talking about getting close to people, getting in their safe zone and connecting with them, maybe not verbally, but visually or with a smile. Those are the things that people bypass or don't really recognize as an option. As dementia progresses, people have increased difficulty responding to their surroundings. Sometimes there's things going on around them that would normally be very comforting, and they don't seem to even notice. The circle of their awareness becomes very, very small. Oftentimes they develop difficulty chewing and swallowing, and that's been touched on a number of times. Their verbal abilities decline significantly. Sometimes they will have periods where they will be very verbal for a short period of time, but then they will go days without saying anything. One of the tools that we use in the world of hospice when talking about dementia is called a FAST scale. And I'll be honest with you, prior to coming to hospice, I had heard the words, their FAST score, but I had no idea what it meant. We refer to it now as, sort of the Bible of dementia, but it should be noted that the FAST scale is largely designed around Alzheimer's. It doesn't necessarily apply well to the other forms of dementia. And I know this probably isn't coming across great because it's fairly small text, but in the FAST scale is a numeric scale, and in the smaller numbers, the 1 through 5, that's kind of early dementia. People are noticing issues at work, having trouble managing their own finances, Maybe they, it's the middle of winter and they put on a tank top, things like that. But nobody's super worried at this point as a general rule. I mean, their families not getting up in arms and looking for a lot of assistance. Then we move into that moderate stage of dementia, and those are the sixes, the 6A, B, C, D, and E. And these are the people who are really struggling on their own. They need assistance with dressing. They're not bathing appropriately. Either they don't see the need for it, or it causes them anxiety, or they don't remember that they need to. I know with my mom, this became an issue. She went from being a very meticulous lady. She was a hairdresser all her life. And then I started to notice a lot of hygiene issues. But she was cognizant enough to be offended when I would say something, but not really accepting of my assistance. For me, this middle section of dementia was by far and away the hardest. Gradually, she got to where she wasn't flushing the toilet. She wasn't able to clean herself after toileting, intermittent incontinence of urine, occasional bowel incontinence. Then as we approach this advanced stage of dementia, this is where the verbal abilities really start to decline. The 7A is they use fewer than 6 intelligible, sort of meaningful words in a day. By 6B, their average day, they may only have one appropriately used word. And then they start getting to the point where they're unable to ambulate without assistance, can't sit up independently. They need a wheelchair with lateral supports, or they need to be propped because their trunk strength is declining. Then we get to the point where they no longer smile. They no longer respond to things that would normally create a smile. Seeing family members that they may not know, but they know are familiar, or a baby, or things that previously had been a source of joy for them. They just don't show any sort of an emotional response to. And then sort of the last, I guess not the last stage we look for is that lack of ability to control your head. Now, the reason I brought up the FAST scale was because this is a key component in accessing the hospice benefit. There are federal guides called the LCDs. And that is the, what does that stand for? Local, hang on, I'll think of it in a minute. But they're the criteria that we use to deem whether a patient is appropriate for hospice or not. And they need to be up in this 7 sort of area. If a patient has Alzheimer's alone and they're still verbal, still talking, still able to ambulate fairly independently, they generally have about a 2-year-ish life expectancy. So once they start to get into the 7 range, that life expectancy becomes much closer to that 6-month expectancy that the Medicare, Medicaid guidelines sort of deem necessary. Quality of life issues are very significant with dementia. Data shows that people with dementia have generally less well-managed pain, especially in a nursing home setting. The tools that we use to evaluate and measure pain don't work very well with advanced dementia because a lot of the evaluation of pain is a self-report. And these are patients who, even though they can indicate pain, they can certainly feel pain, their ability to communicate pain is significantly impaired. many patients with dementia do not have advanced directives. And when the families, often when families get to the point of saying, oh wow, we really need to get mama an advanced directive, then she's no longer at the point where she has capacity to really contribute effectively to that. It just makes for a more challenging, not impossible, but more challenging advanced directive. People with dementia undergo a lot of burdensome diagnostics and interventions if their needs aren't, or if their wishes aren't well known. And people with dementia often receive less hospice care. People just do not see this as a terminal diagnosis, including healthcare providers. As has been mentioned multiple times today, the nutritional difficulties, recurrent infections, use of antibiotics, CPR, repeated hospitalizations, and pain all become issues as dementia progresses. We have touched on the dysphagia component, the nutritional intake component. Dysphagia is, for those of you who are non-clinical, is an inability to chew and swallow food. Now, this can be either oral. People are pocketing or spitting out food. Sometimes that's because of textures. Sometimes it's taste. They don't like it. They don't seem to, like the food that they're given. But other times it's a pharyngeal problem. They have difficulty or delayed swallowing. They cough consistently when they swallow. Other times it's just simply the task of eating, managing utensils, knowing what to do with the utensils, recognizing that food needs to go in your mouth. All of that can be a problem. Sometimes it's decreased appetite. Oftentimes dementia comes along with a whole horde of other diagnoses, which may or may not play into progression of their dementia. Sometimes it's dental issues they can't tell us about when they're refusing to eat. The other thing that I evaluate frequently when my nurses will say, they're just not eating. We will evaluate for depression. And that's not as easy as one might, it's just not easy in dementia to evaluate for. As was mentioned earlier, there is just no evidence to support significant benefit in the use of PEG tubes versus hand feeding in advanced dementia. In the hospice world, I spend a lot of time on this with families. Most of the time it's education. It's worry that their loved one is going to suffer, starve to death is a phrase I hear frequently. And it's having a emotionally connected, meaningful conversation with the family is usually what it takes to deal with that issue. Some of the interventions that I will suggest, and we spend a lot of time educating skilled and non-skilled facilities on this as well. If you bring somebody with dementia into a busy hubbub with a lot of movement and noise and dishes clanking, it's very distracting. It's very upsetting to a lot of folks with advanced dementia. So sometimes it's as simple as allowing them to eat in a calm, quiet setting without distractions, or maybe just with music that they enjoy, or where they can focus on the task at hand, which is eating. We offer, but never force food on people. Dementia is no different than other areas of medicine in that as people grow older, they frequently do not want one big meal every, 6 to 8 hours. Older people often prefer to have small snacks throughout the day as opposed to big meals. Sometimes it's textures. Sometimes we have to do dental soft, if they don't have great dentition. Sometimes we have to do pureed. It's the mixed textures in their mouth that create swallowing problems. Sometimes people say, you know what, if you thicken my coffee, I'm just done. I'm absolutely okay with that. And so if they don't swallow well, but they don't want thickened liquids, as long as they know the risks, that's absolutely okay with me. I tell people all the time, you are the captain of this ship. Allowing plenty of time between bites. Sometimes the process of chewing becomes very slow, very methodical, and pocketing food. Sometimes we'll see people 2 hours later will spit out, whatever we fed them hours before. Infections can be challenging in advanced dementia for a couple of reasons. One, is this something that we want to treat? And honestly, at the time of the infection is the worst time ever to have that discussion. These are discussions that I try and have with the family well ahead of time. Oftentimes we have to have these discussions multiple times, and then it's not such a crisis decision, because in a crisis, people often react, they don't respond. And so those are discussions that we try and start early. But we see all the time, we get calls from skilled nursing facilities telling us that, Marla has some behavioral changes, and we think she's got a urinary tract infection because her urine's concentrated. Well, there is an insane amount of antibiotic overuse that happens in dementia. Every time they have some behavioral differences, the response is frequently to try and treat a urinary tract infection or something else. And that is more often than not just not the case. And so with antibiotics used for urinary tract infections in dementia, about 80% of the time when UAs are obtained, they do not meet the accepted guidelines for treatment of a urinary tract infection. So I think part of that's on here. Antibiotics, as a general rule, do not provide comfort and don't improve survival time. Am I hitting my time? Oh, look at you. Okay. So I know I have a ton of slides, it looks like, on here, and there's a lot of information for, your perusal at whatever time you want. But
Dr. Mallberg, you could take 2 more minutes if there's a couple things that you wanted to touch on before we end.
One of the other things that I guess was important to me that I wanted to kind of reiterate that was brought up earlier was the agitation and comfort cares towards the end of life. I know on my slides, I do list some medication options and things that I was going to kind of talk through, but I absolutely agree that medications are so rarely the right answer. The vast majority of times, and I've had this discussion with my nurses many, many times, is there are a handful of things in this scenario when patients are agitated that we can deal with. Okay. The biggest one is us and how we respond to it. The other one is the environment. We can do very, very little to change the patient's response, but it's those other things that we can adjust. Making sure that they're not constipated, that they have peed, that they have eaten, they don't have wounds. But outside of that, The things that we change are us and the environment, the vast majority of the times. The medications typically are reserved for the very, very end of life, maybe delirium or restlessness that happens in the immediate dying process. So they're tools in the toolbox, but I rarely bring out a hammer for things that we can manage just by rearranging.